It's a very important question, and we have a wonderful answer. Cataract surgery is change. Now our goal is not only restore the vision, but provide high quality vision. And that is a tricky thing, but now is effective and real practical. Why? Now was introduced trifocal technology, EDOF technology, and pinhole technology. The scenario is completely changed, and now we have the ability to provide this technology in over 75% of our cataract patients. I think that there are a lot of advantages because to correct presbyopia in the most effective way is a dream. When I started to perform surgery 40 years ago, it's like to think to land on the moon. Now it's a reality, and that is very exciting. But we have a problem. The problem is that we have to change totally our feeling, our organization, and we have to put in the basket all the new technology that help us to provide the best result. That is very difficult because it's costly. We needed to change our mind. We needed to be expert in a field and in novelty where naturally, if you are a pioneer, you are not expert. And when you are a pioneer or adopting something new, a lot of problems that you, one after the other, have to overcome. Naturally, what we have faced? We have faced with a bifocal IOL for the last 10 years, some very important weak points, loss, glare, and quality of vision for far was a problem, a real problem, and that mainly for driving overnight. So that is what we have studied on. And now trifocal is the technology that is approved for far, intermediate, and near, because intermediate was lost. So we have a tool for 10 years that can't apply to the people, because for people, the most important thing is not near, but intermediate, is iPad, iPhone, computer. And once we have understood that, the research switched naturally in a technology that has not this weak problem for distance. What I mean, trifocal technology is still a little bit sensitive to refractive result after cataract surgery. I mean that if you get a metropia, you are the best. But if this doesn't happen, probably your patient has something to complain. So the concept of a small aperture IOL is that the pinhole is well known for the last 3,000 years from the Egyptian, eliminate halos and glare and make a focusing for far in so an effective way that you don't need to manage astigmatism up to 2 diopter, and that is a revolution. One more time, we needed to clarify. We have a trifocal that is submitted and approved for distance, intermediate, and near vision. Then we have EDOF, that is a marvelous technology, but is submitted and approved for distance and intermediate. No vision is not approved for near vision. And now we have the pinhole that has these two main characteristics. First of all, is implanted only in one eye, in the non-dominant eye. So what does it mean? It means that the dominant eye is implanted with the most advanced aspheric monofocal IOL, and so no doctor, no patient have to complain about the distance quality of vision, because it's the best and we have no discussion about that. So the dominant eye that is dominant on the other eye for distance is perfect. Then the really important information is that the pinhole provides distance vision. Why? Because normally 80% of the patient, due to the pinhole effect, see 20/20. And that is not monovision, as monovision works. So at least 20/25. So you have bilateral, perfect distance with monofocal aspheric and with a pinhole effect that correct up to 2 diopter of astigmatism. Naturally, this is to be judged for intermediate and near vision. Near vision is a monovision, naturally. Why? Because we have a monofocal aspheric and we have the pinhole. But surprising us, to mix the two things, the result is effective. I have implanted 25 patients with quite 2-year follow-up, and no one of these patients is using glasses at all. In conclusion of this very important topic, that is a real revolution, because it's difficult for eye doctor, for the surgeon, to understand that and to adopt that. In my country, in Italy, 99% of the eye doctors are not using advanced technology, or they have not enough direct experience with this technology to have the opportunity to judge it and to decide what is the best for their own patient. So that is a general concept. We are facing a very exciting time, but we need to understand that the cost is, for the first time, is a great barrier. And this is something that needed to overcome our old mentality. We needed to be open-minded. Also, we are expert surgeon, and we have many, many years of experience, because we know that nobody can stop the progress. Coming back to this meeting, in my opinion, is growing up in a very important and dramatical way. Why? Because, you know, everybody knows that this meeting in the past has some decline. But now, after having focalized that the residents are a very fundamental topics for the organizing this meeting, now there is a positive evolution. There are over 150 opinion leaders that increase the importance and the significance of the faculty, and so that is a perfect match, because we have residents, we have young ophthalmologists, we have normal doctor that can come in a meeting that is open to their need, but also provide the best quality about the information, about what we need daily, and that is really important. So what I mean is, you know that there are some group of experts that internationally go around the different meetings and create a specific important basket of the most advanced and the most scientific based information. I think that also the SOE has adopted this system, and so I am very confident that in the next, besides the competition that is normal and very aggressive, this meeting will grow, but will grow not only for organizing problems, but because I hope that in the mentality of the eye doctor, they judge this with a very precise, important, and effective tool.